I got a patient who's 50 years old, female. Physiologically, she was 60, had chronic on and off pain in the knee, and had a trivial fall on the level ground 6 months ago and sustained injury to the leg. She was not able to walk. She went to quack and she was not liking doctors or hospitals, so she was not getting any treatment. So this is X-ray 3 months after initial fall, and she did not take any treatment. And this is a subsequent X-ray at 6 months post that trivial fall. So can I ask the panelists, Dr. Abe, at this stage, any plan in the mind?
Obviously, she has an arthritic knee, which needs a total knee, and she's got a stress fracture, probably an ununited stress fracture of the proximal third of the tibia, which needs additional support and fixation with the tibial stem. So the femur would get done normally, your balancing would get done normally, the tibial, the tibia preparation would get done normally. Only thing is you can't put in an intramedullary jig, so you'll have to probably do a partial osteotomy, correct it on the table, put a unicondylar plate, and bypass that stress fracture with a stem and get at least 2 cortical diameters fixation with the stem.
Okay, sounds good. Dr. Rajkumar, you want to say something?
Yeah, we have published this. In my hands, what I will do is almost same, but only thing is I will not try to open the fracture site, do a TKR, do a reamer, use the reamers, and then ream it nicely. Majority of the time, automatically it gets corrected unless it is malunited.
Okay.
If it is malunited, then it needs to be opened up, correct the by osteotomy, and then do the TKR, add a thicker stem.
Right.
And most of the time, once you correct the alignment, the biomechanics, the stability will be there. If rotational instability is there, then add a plate.
Okay.
And also do a fibular osteotomy.
Right, you will do fibular osteotomy.
Yep.
So those were the questions, Dr. Sharma, sir.
Can I add one thing? See, these are the cases which can be dealt with in a very simple way. If you are tibial cut first surgeon, there's a problem that how to make the tibial cut.
Yeah.
So in these cases, if you start with the femur cut first, and then go ahead with the tibial cut, parallel to the posterior cut of the femur or the anterior cut of the femur, then these cases becomes very, very simple, as Rajkumar has explained. Without opening the fracture line enough, you may do a partial osteotomy, as Abhay was saying, and then use the bone graft that you are going to remove the removed bone. You must use it as the bone graft.
No,
so these cases unite very.
You're going to use like opening and using the grafts?
Yeah, just a mini opening.
Mini opening, but you're not going to fix it.
Yes.
Dr. Anil Arora?
Yeah, I want to add something, because if you take an extramedullary jig in such situation,
Yeah.
and though it is correctable, so suppose it is not united, it is largely correctable, then what I do differently, I used to tend to put an intramedullary jig, take the tibial cut after taking femoral cut, and then balance the knee, rather than taking extramedullary jig, because if you do an extramedullary jig and then try to put a stem, it becomes difficult. It might penetrate, it might hit the cortex. So to start with, the entry point to open up in the tibia is a bit lateral, then go down, use the intramedullary jig, take a tibial cut, and then go ahead further.
I think that's perfect. That sounds good.
I think the point here is you need to have a stable tibia before taking the proximal tibia cut.
Right.
So if you are going to use extramedullary jig, you need to stabilize with some fixation modality. Otherwise, the best alternative is, as was Dr. Anil Arora suggested, intramedullary jig to take the proximal tibia cut. That's very important.
I think another point, it was sort of correctable when after anesthesia, passive stretching, the deformity at the fracture site was reasonably correctable. So that was a bit positive. So I did femur first, and as Dr. Anil Arora mentioned, we tried to put a reamer in, sort of create a medullary cavity, which was a great task actually. It was not that easy. We had to use the Steinman pin, you had to use the drill bits, power reamer, everything, whatever we had, and eventually we created a passage, and this is what we gained afterwards. Any comments on this case? I had a shorter rod, unfortunately, that was the only rod available to me. That was, should have been a longer rod actually.
The, okay, the X-rays are rotated, so we are not able.
Okay.
But a thicker stem, little bit. If what is the longer stem is would have been an uncemented longer
Okay,
stem.
so the time is over, so I think we'll have to show 4 months later, and that is 9 months later. She is doing perfectly fine and no problem so far as pain is concerned and anything.
I think the point here which needs to be emphasized here, like Dr. Raj said, fibula osteotomy. I think you had put up the bone grafts in that osteotomy site. Did you?
No, it was closed. No, I did not open. It was just internal reaming, and that worked.
See, majority of the time, the internal, whether it is correctable or not, if it is getting corrected, the biomechanics is corrected, internal reaming itself will create a bone graft around that, no need to open. The opening that area, again, soft tissue problems are high.
Yeah.
Try to avoid it. At the end, you keep it. And then the fibular osteotomy allows still more collapse at the fracture site. And once the biomechanics is corrected, collapse at the fracture site, good weight loading, automatically it heals off.
Thank you. Thanks a lot.
Can I come in?
Thank you.
Okay.